For those who don't know me, my name is Chris Spelman. I'm a paediatric and adult hip and knee surgeon. My talk today is hip pain in children and adolescents, which I'm sure a lot of you see very regularly in your practice. So when assessing kids for hip pain, your biggest differentiator is the child's age, more so than the symptoms they're coming in with, more so than their history. The age will give you the answer to most of the problems that they're going to come with and really narrow down your differential list when you're seeing them. We'll talk a bit about the imaging decision making, who needs x-rays, who needs MRIs, who needs ultrasounds. The answer to that is no one except babies. And who needs to be referred on to me and who can you manage yourself. So starting out, we've got infants from 0 to 2. Now, hip dysplasia is the most common problem for these infants. It's rarely painful before the age of 2 years old. We do get children presenting with limp, which is normally due to a leg length discrepancy from a missed dislocated hip at birth. It's unfortunately still very common. We don't have a universal screening program in Australia for hip dysplasia like some of the Scandinavian countries do, and it's just on a referral basis. So we do get quite a few missed hip dysplasias or hip dislocations in babies. The most common cause of pain in 0 to 2-year-olds is septic arthritis or osteomyelitis. They can also get transient synovitis, so inflammation of their joints following a viral infection, classically a gastro illness, but it could be anything. This is uncommon in children under 2. That's normally in slightly older children. So your first thought if you've got a kid that's limping with new onset hip pain should be, is this an infection? And then more commonly than you'd think, we do get tumours presenting in these young children, and it's important not to miss them. Fractures in 0 to 2-year-olds, we're really worried about non-accidental injury for any baby that comes in. So any child that's not walking with a femoral shaft fracture or with any torsional injury to their tibia or femur, you're worried that it's a non-accidental injury and they need to be referred to the child protection unit at the Children's Hospital. So just running through a few quickly, we've got a 4-month-old who had asymmetric buttock creases picked up at their newborn check. And you can see here on the hip ultrasound, on the left, we've got a normal hip with excellent coverage. 60% of the ball is underneath the pelvis. Labrum's in a good position. That's what we want to see. And you can see on this right hip that only about 20% of this ball is in the socket. Now, because this child is under 6 months of age, it's very, very easy to treat this with bracing. So providing clinically you can reduce this hip, which it should be, as you can see, they'll be almost certainly get away with not having any surgery. Slightly older baby. So this is a 2-year-old who was treated for DDH as a child who came in with pain, which is very unusual for a 2-year-old. Now, their x-ray doesn't look too bad, but their acetabular indices, so that's the measure of the steepness of the roof, is high on both sides. We want to see this at about 20 degrees, which would be an angle like this. But they're up at about 32, which is unacceptable for a 2-year-old. But because it's picked up quickly, we can intervene. At 2 years old, this is 5 weeks post-surgery, they've just had what's called a pemberton osteotomy, where we essentially bend down the roof and put a bone graft in there. This child didn't need a hip spiker. They walked into my office 5 weeks after surgery, after having bilateral pelvic osteotomies. So kids at this age, if you intervene, will recover very, very quickly. This is the scan of a 13-month-old that I saw a couple of weeks ago, actually, who started walking and then stopped walking 4 weeks afterwards. And the mum had noticed that they had a bit of swelling in their thigh and presented. You can see here they've got this enormous bone cyst in their proximal femur. And then on the MRI scan, they've got fluid levels in that. So this is actually a very large aneurysmal bone cyst, which although it's uncommon, does present. This is only in the last month that I've seen this child. So if you're worried, the take-home point is just get an x-ray for them. For young children, so 2 to 10, the differentials change, and the most common presentation is Perthes disease. Now, it's classically between 4 and 8 years of age, but can present any time in this. Hip dysplasia in 2 to 10-year-olds starts to become painful as the childs grow and become heavier and start demanding more of their hips. and it becomes particularly symptomatic later on, but we do get a lot of 5, 6-year-olds presenting with mild hip dysplasia. Transient synovitis after a cold or viral illness is very common also, and then there's a long list of less common differentials that pop up here. This is a pretty barn door obvious one for anyone who gets an x-ray for it. This is an 8-year-old who presented with a limp and a short leg. And you can see they've got Perthes disease in their right hip. They've got flattening collapse of their femoral head compared to a normal hip on the left-hand side. Now, this x-ray is labelled AIR, which actually is abduction internal rotation. So that's the x-ray that we want to get for children with Perthes disease, because we want to see, is the femoral head reducing into the socket or is it hinging out to the side? Because that really dictates what we're going to do for them and how we're going to manage them, and if they can be managed non-surgically. So if their hip's reducing, we can manage most of these kids without surgery. This is an example of a 6-year-old with hip dysplasia that was never treated as a baby, and you can see they've got bilateral hip dysplasia with the left hip less severe than the right, which is coming out. Now they start getting pain because you're loading their labrum, and the labrum's overused and starts to become painful, generally 6 to 8 years of age if it's severe, and generally about 12 to 14 if it's mild. You can see they've had bilateral pelvic osteotomies, so similar to what you saw before, and bilateral femoral osteotomies, and now have very well reduced concentric hips and are unlikely to need any further intervention for the rest of their life, because we got to this early before the labrum was damaged and before there was any cartilage injury to them. Teenagers, again, a new category for them is SCIFI, which is their most common presentation. We see probably one a week at the Children's Hospital at Randwick that's severe, that requires surgery. I'll show you a few pictures of that in a minute. The 10 to 16-year-olds is when the kids are playing more sport, they're more active. The single most common group I see are dancers and gymnasts. So they're all very fit, very athletic 14-year-old girls who start presenting with hip pain because they're expecting something of their hip that your hip is just not designed to do. Your hip is not designed to be above your head when you're exercising, but because of the nature of their activities, they're putting a lot of stress and a lot of loading through their hip joint. We start to see some pain from hip impingement in 10 to 16-year-olds, but that's uncommon. It's more common in older groups. And labral tears in this age group are probably 80 or 90% due to hip dysplasia, unless they've had a significant traumatic injury. So a SCIFI, you can see here, on the left hip on this x-ray, the femoral epiphysis has stayed static inside the socket because it's well contained, and the metaphysis has moved and migrated rather than the head falling off, which is what most people describe it as. These always need to be managed surgically, and the decision making for this is, do you pin the other side or not? And there's a few radiological parameters that we can use to determine that. But most of it is the end of the bed test. Is this child going to come back for follow-up? So if they're from Grafton and they live out on a property and it took them a year to present with hip pain for the first time, you just pin the other side because you're worried that they'll end up with 2 severe slips and then lots of problems. Here's one actually from a couple of weeks ago who you can see has bilateral severe slips. This is very uncommon. There's a lot of information I've put in the handout about SCIFIs and what you need to know, and we'll talk about that briefly in a few minutes. But what you need to know is, can they weight bear? Because that's the single most important predictive factor of how they're going to do. So if they can weight bear, the slip is stable, they have a low AVN rate and they will be fine. If they cannot weight bear or they need crutches, then the slip is unstable. They've got a 50% AVN rate no matter what we do for them. So half these kids will have a hip replacement by the time they're 20 if they can't weight bear. This is an x-ray. This is a 14-year-old girl who was a very, very good dancer who presented with about 6 months of indolent right-sided hip pain. And on first glance, her x-rays don't look too bad, but if you look closely, the right femoral head is more uncovered than the left. Now, she had some success from reducing her activities, but she was studying dance for HSC, or was planning to. So when she wasn't getting better, came to me with an MRI scan. And when you look closely, she does have a big labral tear on her MRI scan, but her problem is hip dysplasia. So she has this labral tear because her hip socket is not stable and she's overloading it, and the combination of dancing and the socket is what's caused this. So in general, if we're talking about labral tears, they can be managed conservatively in children, and a lot of them will heal without any intervention, but only in the setting of the mechanics being correct. If the mechanics are incorrect, the labral tear will never heal, and they'll have ongoing problems. So she's had a periacetabular osteotomy to redirect her acetabulum and provide much better femoral head coverage. You can see her lateral center edge angle, if you measure it, is now 35 on this. And at 6 months, she's back dancing and doing her rehab. Another example of a 15-year-old coming in with pain. So this is a girl that was treated as a baby for hip dysplasia and then lost to follow-up. You can see two very different hips here. The left one has AVN, secondary to her treatment as a baby. She was actually treated in a spiker with a closed reduction and has unfortunately ended up with AVN with a flattened femoral head and a Perthes-ish hip. So, you know, same kind of mushroom-shaped femoral head, but her GT isn't high, which is the key. So the Perthes kids, their trochanter will be up here above the level of their acetabulum. She's got hip dysplasia on the right-hand side as well, but that's not symptomatic at the moment. So what she needs is a correction of her mechanics in order to fix her pain. So she's had the pelvic osteotomy and she's had a trochanter distalized in order to center the abductor insertion with the middle of her femoral head. These are big operations. They take them about 6 months to get over these kids. They're on crutches for 3 months. So it's a big undertaking for these children. But you know, this girl's now 2 years down the line. She's playing touch football, running, and has no problems. In terms of hip dysplasia, the most important decision is who needs screening. So if you look in the handout, there's a list of risk factors there. Essentially, all of my children will have a hip ultrasound. It's a non-invasive test that will pick up a problem that can be managed very easily if it's picked up early. We have no universal screening. So if you're going to make an evidence-based decision-making, breech babies, any baby with a family history must have an ultrasound. Other than that, you can, if they've got asymmetric abduction on exam or anything that you're worried about, just get an ultrasound for them. Management in infants is very simple. If the hip's reducible, they get a brace. There's lots of different types of braces that I'm sure you've all seen. Management in toddlers is a bit more difficult. They don't tolerate bracing and need surgery. And management in older children, if they've got mild or moderate hip dysplasia and symptoms, they get surgery. If they have no symptoms and they've only got mild hip dysplasia, we watch and wait, but they all become symptomatic eventually. For Perthes disease, there's about 9 different classifications used for Perthes disease, 5 of which are used commonly. And any disease process with 5 classification systems is one that is not well understood. If we knew what we were talking about, there'd be one overall classification system for it. The most important thing from a physio perspective is what stage are they at in their time course. So Perthes disease has an initial phase where it's inflammatory and they get synovitis and pain. The head then fragments and starts collapsing. The head will then reossify over time and form back into a mushroom-shaped ball, and then it will remodel after it is finished reossifying. And what we want to do is minimize the kids' pain, maintain their range of motion, and we want to minimize loading and weight bearing during the initial fragmentation phase, because while the head is collapsing, that's when the damage is being done. And we can prevent that by reducing their running, jumping, sending kids, you know, in a wheelchair to school for 3 months, just in that initial phase, not long term. The Americans keep kids in wheelchairs for 2 years with Perthes disease in an abduction brace. I personally think that's cruel and unusual punishment. Transient synovitis with septic arthritis is not something you're going to see a lot in practice. Essentially, anyone that you're worried about, send them to hospital. If they've got septic arthritis, they will be febrile, they will be unwell. If they've got transient synovitis, they won't have fevers, they'll have normal blood tests and won't need anything else done. This is the other group that an ultrasound is useful in, because you can see if they've got a big joint effusion, you can see if there's a collection underneath the periosteum in kids, which is where they tend to manifest it. Trauma is increasingly common now. I don't know if it's a COVID thing or what actually happened, but we're seeing a lot of kids coming in with, quite high energy injuries, the majority of which seem to be from mountain biking and dirt bike riding, as well as riding quad bikes and rolling them on farms and car accidents. We'll talk briefly, so fractures of the pelvis and the femur are not going to come to you initially, but will come to you for their rehab afterwards. And they all need to be managed on an individual basis, so there's no overarching guidelines for it. We see in the last 12 months, I've had 3 traumatic hip dislocations in children, one of which was a very bad one that I'll show you an x-ray of, and 2 that were just standard rugby tackle, couldn't stand up afterwards, and a fit and well 14-year-old's got a dislocated hip. Now, they can be treated, if there's no fracture, they can be close reduced and they'll be fine, but the ones with fractures obviously are ending up with surgery. Avulsion injuries is what you're going to see a lot of in your clinical practice. In children, almost all of these can be managed non-surgically. The exception being a complete avulsion of the hamstrings from the ischial tuberosity needs fixing. But if it's displaced 1 millimetre, we can watch it. But if there's a complete avulsion of the hamstrings, that needs surgery. And the other one that you'll see are the grumbling AIIS avulsions. So you'll see these classically in soccer players. It's a pivoting, kicking injury because they hyperextend their hip and then their rectus pulls off their AIIS as they contract it with their hip hyperextended. These will normally heal without surgery, but kids that don't listen and go back to sport too early will just continually pull this AIIS fragment further and further and further over time. And these ones, while uncommon, do need surgery. This is just an example of the trauma that we've had this year. So this was a mountain biker who went off the side of a trail, and you can see he has a fractured dislocation of their hip with a femoral head fracture in there. Now, he's had this reconstructed, had the hip opened, had everything put back together. He's 12 months down the line now and is running and jumping. These are ones that are obviously taken very slowly with their rehab. Now, there's a lot of other detail in the handout because I don't have time to cover it. If you've got any questions, please just come and ask me at the morning tea break or on the panel. Thank you.